Hello everyone, I'm Dr. Tripat. Yesterday was World Sleep Day, and today we are here to discuss a few facts about sleep uh, so that we can take care of our patients and general community in Malaysia in general. I will present some facts which will, I think, is a wake-up call for Malaysian medical community. So what I'm going to do is I'll take you through the scenario in Malaysia regarding sleep health. And I will be discussing three things to build up my case that it is a wake up call in terms of sleep disorders, sleep pattern, and sleep education. So, before we start, you need to know that there are more than 84 type of sleep disorders according to International Classification of Sleep Disorders 3rd edition, and there are 6 categories for that. The first category is insomnia. Second category is sleep disordered breathing, under which obstructive sleep apnea and central sleep apnea come. Hypersomnolence of central origin, in which patients are very sleepy, and diseases like narcolepsy, idiopathic hypersomnia, Klein-Levin syndrome comes under this category. Then there are circadian rhythm disorders of sleep and wakefulness, where your circadian drive is altered, and common examples are jet lag and children facing difficulty in waking up in the morning and sleeping at night, which is called delayed sleep phase syndrome. Parasomnias like sleepwalking, sleep talking, nightmares, sleep terrors, and movement disorders like restless leg syndrome and periodic limb movement disorder. So these are some of the common disorders that are quite prevalent across the globe. Now let's see what is happening in Malaysia as in terms of sleep disorders. Before I go to Malaysian data, look at what is happening around Malaysia. If you go to Singapore, they have very robust population based data where they have shown that around 30% of the population have moderate to severe obstructive sleep apnea. And overall prevalence has been reported in 1999 was 15%, which has increased to 30% in 2016. If you look at Thailand, they have reported in 2011 that 15.8% men and 6.3% women had obstructive sleep apnea. If you look at Indonesia, they also report that 16% men and 17% women have obstructive sleep apnea. Whereas if you look at Malaysia, there is general population data is not available, and I'll show you what data we have. So in Malaysia, the first study shows that among commercial express bus drivers, 28% of them have mild OSA, 9% of them have moderate OSA, and 6% of them have severe obstructive sleep apnea. Now, this can be should be of concern to the medical community because such a high prevalence of untreated obstructive sleep apnea among bus drivers can lead to road traffic accidents. If you look at among the young doctors, now this study was done on 52 Thai and Malaysian doctors whose age was less than 40 years of age, and 38% of the doctors were of Malay origin. And what this study found that in these doctors who are younger than 40 years of age, 26% had mild OSA and 13% had moderate obstructive sleep apnea. And OSA prevalence was higher among males as compared to females, whereas symptoms of tiredness, perception of inadequate sleep, sleep deprivation was present in both males and females to the same extent. That means not only among bus drivers, OSA is quite prevalent among the medical community itself. If you look at the prevalence of obstructive sleep apnea in patients who are undergoing open heart surgery, in this study, again done in Malaysia, they found that these patients who are undergoing open heart surgery, around 56% of them had mild OSA, 21% had moderate OSA, and severe OSA was present in 22%. Again, high prevalence of obstructive sleep apnea in patients who are undergoing open heart surgery. And on stop bank score, high risk was found in 70% of the patients. That means they are not even diagnosed at the moment. Another study looking at Asian bariatric population and obstructive sleep apnea. This study was again done in Malaysia. The overall sample prevalence of OSA was 80.5%. Of these, 24.3% had mild OSA, 23% had moderate OSA, and 32% had severe OSA. Very interestingly, only 17% had been diagnosed with OSA before bariatric workup. That means more than 80% of these cases are undiagnosed. This is a very serious situation because this highlights two facts: that disease is highly prevalent in different disease populations, whereas as medical community we are not doing enough to diagnose these cases in time. If I look at association between sleep apnea and young adults with hypertension, this study found with high hazard ratio, odds ratio of developing hypertension if you have OSA, especially severe obstructive sleep apnea, have high odds ratio even when adjusted for confounders. So they found a relationship between sleep apnea as measured by AHI and hypertension in young adult population of 18 to 40 years of age group in Malaysia. In this study, which was done in patients undergoing polysomnography test at UKMMC in Kuala Lumpur, the patients were recruited between 2011 and 12 in the age group of 20 to 60 years. They found insulin resistance to be directly proportional to the severity of obstructive sleep apnea as assessed by AHI. Higher the AHI, higher the insulin resistance in patients. If you look at quality of life of epilepsy patients obstructive sleep apnea in Malaysia, this study, they did quality of life in epilepsy questionnaire based assessment of social functioning, negative effect of medication, cognitive functioning, energy fatigue, emotional and overall quality of life in epilepsy patients who have OSA before treatment with CPAP and after treatment with CPAP. And you can see all these domains were affected before OSA was treated, and after OSA was treated with CPAP, all these domains in epilepsy patients had considerable improvement. That means if we diagnose OSA in these patients and treat it with CPAP, their quality of life improves. Now, this brings me to the point that OSA is highly prevalent among different disease states, and if we look at international data, OSA is highly prevalent in different disease states as well. That means Malaysia is no different from rest of the world in terms of prevalence of OSA in different disease states. Only thing is we have limited data. We need more studies studying OSA in different disease populations as well as general population. If you look in pediatric age group, now this study was done in Asia Pacific, and if you look at the Malaysia data, around 5% of the kids had habitual snoring and 30% of the kids do snore at some point of time. And interestingly, the parent reported problems in their children regarding their sleep. Malaysia was at number 3 after China and Hong Kong. Parents in Malaysia perceived that their kids have some kind of sleep problem, which can be bedtime routine, sleep terrors, nightmares, bruxism, growing pains, daytime sleepiness, or daytime behavior. And Malaysia was at number 3 in ranking in reporting parental reporting of sleep problems. Insomnia. It is 60% of the patients in Malaysian primary care patients reported insomnia symptoms, and around 39% of frequent insomnia symptoms, and factors like Indian ethnicity, age more than 50 or older, anxiety symptoms, depression symptoms were risk factors for chronic insomnia with daytime function. A type of hypersomnia disorder called Klein-Levin syndrome has been reported in Malaysia. And if you look at daytime sleepiness and sleep quality among Malaysian medical students, 50% of the students reported bad quality of the sleep. Now, this brings us to the point that all type of sleep disorders are prevalent in Malaysia, and we need to do more studies to understand what is the burden of OSA in more disease categories, and also we need to do more studies to understand what is the prevalence of OSA in general population. Now, by understanding that sleep disorders are highly prevalent in Malaysia, let's look at what is happening to sleep patterns in Malaysia in general. So, for that, I would like you to remember these National Sleep Foundation recommendations about the duration of sleep in different age groups. And I want you to remember these two figures. In preschoolers, 3 to 5 years of age, they need 10 to 13 hours of sleep, and 6 to 13 hours of children, they need 9 to 11 hours of sleep. And in the first 2 years of life, you need anywhere but between 11 to 17 hours of sleep. Let's look at how Malaysia is doing on these figures. So in this study, which was done in Southeast Asian region in preschool children from birth to 3 years of age, Malaysian children were getting the second lowest sleep among rest of the countries. Singapore kids were getting the least amount of sleep. Malaysia was second in number in getting the least amount of sleep as compared to the neighbors. Maximum sleep in this age group was getting in Vietnam. And remember, in the first 3 years of life, I told you, you need 11 to 17 hours of sleep. So kids are getting 12 hours. That is the good news. But as compared to other nations in the region, Malaysia is getting the second lowest sleep. If I look at consolidated sleep during the night in this study, Malaysia was getting the second lowest sleep after Vietnam. Nighttime sleep was second lowest after Philippines and Indonesia. These kids were having the maximum number of naps, and I'll come to nap data in a while. And the highest number of sleep problems were reported in this age group in Malaysia. And that is something we should notice and be worried about. If I look at kids who were 6 to 12 years of age group in this study in Malaysian children, Malaysia was number one in getting the least number of hours of sleep. This 6 to 12 years of age group was getting only 8 hours of sleep, whereas this recommended hours for 6 to 12 years of age group is 9 to 11. If you look at rest of the countries, which are mostly European countries, they are getting that 9 to 11 hours of sleep in this age group. If you look at Asian country like Korea, they are also getting less sleep than recommended. But Malaysia is number one in this age group in getting less number of sleep. Also, you need to notice the time at which these kids are going to bed. They are going to bed after 10 p.m. and they are waking up at around 6:15 p.m. And I will show you later data that we should be worried about this. If you look at the prevalence of obesity in this age group, this study in Malaysia reported that 20% of the kids in this age group are obese, which is quite high number. Now, these two are different studies, where one study is saying that kids are getting less sleep as compared to the recommended 9 to 11 hours of sleep, and kids are sleeping after 10 and waking up at around 6:15 p.m. And this age group in Malaysia had high prevalence of obesity. How does these two data correlate, and what do they tell us about our next step in action? If you look at this study, this answers this question. In this study, they looked at children whose mean age was 8.42 years. 35% of the children were considered overweight, and they looked at the bedtime and wake up time. A bedtime before 8:30 p.m. was considered as early bedtime, and after 8:31 p.m. as late bedtime. Remember, Malaysian kids in this age group are sleeping at after 10 p.m. That means they are in the late bedtime group. If the wake up time was before 6 a.m., it was categorized as early wake up time, and after 6:01 a.m. as late wake up time. That means Malaysian kids are waking up at around 6:15 a.m. That means they are in the late wake up time. Now, what they found was this group of kids who were having late bedtime, and Malaysian kids are in the late bedtime category, they have high BMI scores. And this late bedtime group, almost 70% of these kids were obese, and around 40% of these kids were overweight. Now, this tells us the story what is happening in Malaysia. High prevalence of obesity in Malaysia in 7 to 12 year age group, and this is the same age group which is sleeping late. So no wonder that there is high prevalence of obesity in Malaysia. Now, this brings us to a point that we need to teach the community about the importance of the duration of sleep, about the importance of going to bed on time, about the importance of waking up at a regular time every day. Now, if I look in adults in population, this was a study done in 21 countries, and Malaysia was included in this. And what this study found that sleeping less or more than 6 to 8 hours increases hazard of total deaths and cardiovascular disease. So those who are sleeping in 6 to 8 hours, they are in the safe zone. But anything less than this or more than this, the hazard of total deaths and cardiovascular diseases increases considerably. Interestingly, this study reported that naps are protective in people sleeping less than 6 hours per night. So this is the graph for people who are sleeping less than 6 hours, and this is the graph for people who are sleeping more than 6 hours at night. That means if you are having adequate sleep at night, try to avoid nap during the daytime. Whereas if you are having less than 6 hours of nighttime sleep, you may need to nap during the daytime. In another study, the sleep patterns in undergraduate medical students in Malaysia, very interesting data has been reported. What they reported is that majority of these kids on weekdays, around 58%, get 6 to 8 hours of sleep, and recommended hours are 7 to 9, but for almost 37% are getting less than 6 hours of sleep. Lot of kids, around 64% on weekdays, are taking infrequent naps, and a lot of kids are taking naps on the weekends. And what they have further reported is that kids who were sleeping less than 6 hours on weekends or weekdays, they have lower CGPA as compared to kids who were sleeping 6 to 8 hours consistently during weekdays and weekends. Now, they are trying to say if you're not sleeping enough during weekdays or weekends, your academic performance will fall. But this study does not report any relation who was sleeping less than 6 hours and who was taking these naps. That data is missing in this study. But it raises very important questions on the relationship between number of hours of sleep at night and the naps. And we need to understand this to educate our students to have a proper balance for their weekend and weekday sleep and the nap pattern. And I'll show you some very interesting data published not from far away but from Singapore. This is the first study done in 31 male adolescents of 15 to 19 year age group. Now, they were divided into two groups. They were sleep restricted, that is, they were given 5 hours of time in bed, and then they were allowed recovery sleep for 9 hours. Then they divided them into two groups. Those who were sleep deprived, they were allowed for 1 hour nap opportunity at around 2 p.m. And the other group, who was also sleeping 5 hours at night, were not allowed to take a nap. And see what happens. Participants who were not allowed to nap showed progressive decline in sustained attention that did not return to baseline after 2 nights of recovery sleep. That means if you are sleeping less and not taking a nap, your cognitive functions are going to decline even though you try to recover sleep on the weekend. Even when they were exposed to second period of sleep restriction, the cognitive function in terms of vigilance deterioration increased, and similar patterns were found for other neurobehavioral measures. Napping attenuated this neurocognitive decline but did not eliminate performance decline. These findings contrasted with the stable performance of adolescents given 9 hours of sleep each night in this study. So what they have come to the conclusion that sleep restriction for the duration of sleep school week has cumulative negative effects on cognitive function. Second successive cycle of sleep restriction result in accelerated neurobehavioral impairment. That is, if you continue to sleep restrict yourself over week after week, your cognitive functions are going to deteriorate as you progress. While afternoon naps do confer some benefit, these together with weekend catch-up sleep appear to be less effective in optimizing neurobehavioral function. And the conclusion is very clear. These kids need to sleep 8 to 10 hours each night for optimal performance. And if you restrict yourself to less than this amount of sleep and try to compensate it with naps or try to sleep more on the weekend, you cannot achieve the same cognitive functions as the kids who are sleeping 8 to 10 hours of sleep each night on the weekdays and weekends. That means we cannot advise to sleep less on weekdays and try to catch up sleep with weekend or with naps to this age group. The second study, again from Singapore, asked the second question. What if somebody is sleeping 8 to 10 hours, let's say, but instead of sleeping in one continuous stretch, they divide the sleep. Like if they're sleeping 8 hours, they sleep 6.5 hours during the night and then take 1.5 hours of nap during the daytime. And they compared the cognitive function with people who are having one continuous stretch of sleep at night. And what they found was if you split 8 hours into 6.5 hours of nighttime sleep and a mid-afternoon nap offered a boost to cognitive function compared to continuous nocturnal sleep. But when total time in bed across 24 hours increased to 8 hours, the split and continuous sleep group performed comparably in tests evaluating vigilance, working memory, executive function, processing speed, subjective sleepiness, and mood. These findings suggest that adopting a split sleep schedule in this manner may be a plausible option for adolescents unable to obtain sufficient sleep at night. So what they're trying to say is that you need to sleep that 8 hours of sleep, and there's an option that you split it across the night and supplement it with a daytime nap. As long as total 24 hours sleep is equal to 8 to 10 hours of sleep, you will do good. But in this case, just remember the data is dividing 8 hours into 6.5 and 1.5 hours of nap. We do not know what happens in 10-hour age group, 10-hour sleep duration. We do not know in splitting this sleep schedules in other ways except shown in this study. And another study done in adults, again from Singapore, in 18 to 35 years age group, who were not sleep restricted, but after learning they were allowed to take a 90-minute nap. What they found was the retention, that is their memory, improved if they were allowed to take a 90-minute nap immediately after learning, especially if they're not sleep deprived, they're not sleep restricted during weekdays. And this study showed that healthy young adults 18 to 39 years of age, if they combined 40 minutes of moderate intensity cycling with 60 minutes of nap period, that before study you do in moderate intensity cycling and then you do lunch, then study, and then take a nap of 60-minute duration, you will have better test performance as compared to napping or exercise alone. Now, these are very important data that should reach our student community in Malaysia. Now, we know that sleep disorders are prevalent in Malaysia. We know there are disturbing sleep patterns also observed in different age groups in Malaysia. That means we have a huge onus for educating Malaysian community and Malaysian general community and Malaysian medical community. Let's look at sleep education in medical schools in Malaysia. Globally, we know World Sleep Society published in 2011 that globally majority of the medical schools, they just devote 2.5 hours to sleep education. What's happening in Malaysia? If we look at the data, this study was published in 2011. A survey was sent to around 10 countries to understand the medical school curriculum for sleep education. And Malaysia was sent but up to 5 medical schools, but none of them responded to the questionnaire. This is worrisome. The same state of affairs was in India. None of the medical schools in India responded to the survey. If you look at your neighbors, Singapore and Thailand, they reported considerable amount of medical education being done regarding sleep education, which should set a precedence for Malaysia to follow. Now, if looking at India data, I was intrigued that what we are doing. So one question that came to my mind was, is it possible to incorporate sleep education in undergraduate curriculum, and can we improve the student learning? So I did a study which was published last year. We did in first year medical college students. We gave them a Ask Me questionnaire, which is a validated 30-item questionnaire that tests knowledge on basic sleep principles, circadian sleep wake control, normal sleep architecture, common sleep disorders, and the effect of drugs and alcohol on sleep. And this was given to 160 students, and pre-test only 10 students scored high on this group, and majority of them scored less than 60%, so low score group. Then we did an educational intervention. We did educate them on the basics of these different sleep topics. And what we found, after education, 90% of them were in the high score group. Now, this encouraged and provided me strong data that yes, it is very much possible to inculcate sleep education into medical curriculum, and with the right curriculum, we can have good student knowledge outcomes. With this in aim, now in India, what we have started is we have started a special national sleep medicine course for MBBS students, where we will be teaching them 6 hours of sleep education, and we are doing it through webinars starting from 26th March, and we will do it over 3 days, this 6 hours of education, which can be looked at for Malaysia as well. What about what is happening to general practitioners? Now, this is a very interesting study from Malaysia, which was done on 207 GPs in Kuala Lumpur, who were given a SACA questionnaire, which is basically OSA knowledge and attitude questionnaire, to test the knowledge of GPs about obstructive sleep apnea. Now, outcomes were they knew most of the correct answers on the questionnaire, so they had good knowledge. But what these GPs reported was they have poor confidence in treating obstructive sleep apnea. They know a lot of things about OSA, but they do not have enough confidence to treat OSA patients. Now, very interestingly, use of OSA screening tools, 90% of them do not use it. And access to polysomnography, 67% do not have access to polysomnography. And around 70% of them are not attending CMEs of OSA. So these were some of the common negative trends that came to highlight from this study, that they have good knowledge but poor confidence, they are not using screening tools, they have poor access to polysomnography, and they are not attending CMEs which focused around obstructive sleep apnea. Now, this brings me to one very important question. Why GPs are not using screening questionnaires in Malaysia? There can be two reasons. They do not know which questionnaire to use and how to use questionnaire. And the solution is yes, we can educate them. The second can be language barrier in using questionnaires. Like a lot of population in Malaysia may not be able to understand English language. They may like to talk and communicate in Malay language. If that is the case, we need to identify what is the cause. If education is the reason, we can always educate them. If language is the barrier, then we need to do some translation for these questionnaires. And the good news is, Malaysia have done a very good job in translating some standard questionnaires into Malay language. Like, you have different questionnaires for subjective measures of sleepiness, like Epworth sleepiness scale. For OSA, you have Stop, Bang, and Berlin questionnaire. Quality of sleep, you have Pittsburgh Sleep Quality Index and Sleep Apnea Quality of Life Index. And Malaysian physicians have done an excellent job in translating Stop, Bang, Berlin questionnaire, Pittsburgh Sleep Quality Index, and Sleep Apnea Quality of Life Index. This is the Malay translation of Stop, Bang questionnaire with a positive predictive value of 84%. Excellent job done. This is the Malay version of Berlin questionnaire with a sensitivity of 92%. and it can be easily used as a screening tool. This is the Malay version of Sleep Apnea Quality of Life Index, and again, fantastic job done by the Malaysian physicians. This is the Malay version of Pittsburgh Sleep Quality Index, which was used in secondary school teachers, and a lot of teachers reported poor sleep quality on Malay version of Pittsburgh Sleep Quality Index. That means if education is required, we need to educate them, the GPs, about which questionnaires to use, and they have these standard questionnaires that have been translated into Malay version. Second question is 67% of GPs in KL do not have access to PSG. Now this is very serious consideration that we need to consider what is the issue in this. If you look at the infrastructure in Malaysia, 21 hospitals in Malaysia have PSG facility, but mostly in and around Kuala Lumpur. Average waiting time for in PSG lab or sleep lab in Malaysia is 3 to 4 months, and it can be longer, some labs going up to 1 year of waiting time. Now that means there is limited infrastructure, and whatever infrastructure is there, majority of the GPs do not have access to it, and there are long waiting times. How do we solve this issue? Do we have alternative care models including home sleep testing available to GPs? Before I go answering this question, what we come to know from GPs in Malaysia is they have good knowledge but poor confidence. They do not have access to the polysomnography. Let's see what happens to GPs outside Malaysia. This was the study published just January this year, which was looking at primary care management of obstructive sleep apnea, and they were looking at various issues that are faced by primary care physicians who are managing OSA patients. Very interestingly, this study found high confidence in knowledge about OSA. Malaysian physicians also have good knowledge about OSA. These physicians have very low confidence in treating OSA. Malaysian physicians also have very low confidence in treating OSA. That means what GPs in Malaysia are facing, globally GPs are facing the same problem. And some of the problems that were highlighted by this study were specialist wait times are unacceptable. Malaysia have waiting time of 4 months to 1 year. Primary care physician report variable knowledge leading to poor confidence in OSA management. Malaysia also report the same thing. And another thing is demanding practice hinders effective OSA care by primary care physicians, and they are unclear who should initiate non-PAP therapies or provide ongoing follow-up, which indicates the poor confidence in initiating different therapies for treating obstructive sleep apnea. And the same thing is being faced by the general practitioners in Malaysia. What are the solutions for this? They have proposed that we should have integrated care models of care where different teams work together. We should have improved system navigation by providing clinical guidelines to inform appropriate use of resources and standardized presentation webinars for primary care physicians. And we should regulate and clearly delineate roles and responsibilities of all providers. So these are some of the solutions that they have given. What can we do in Malaysia in terms of these solutions? What I propose is we can have alternate care pathways of OSA, which is called spoke and hub. Spoke and hub means you have a hub that is your specialist sleep center, those 21 sleep labs in Malaysia, and primary care physicians become the spokes in the periphery where they take care of the patients, they engage the patients, and they become part of the multidisciplinary team along with the sleep center, and they initiate home sleep testing and PAP therapy initiation for their patients in collaboration with support of these sleep centers, these 21 sleep centers in Malaysia. What is proposed is if hub and spoke model, the hub, those 21 sleep labs in Malaysia, they should take care of complex patients who have multiple comorbidities, and this spoke, that is primary care physicians, they should take care of OSA patients who do not have comorbidities and initiate PAP therapy in them, and if they have any problem they can always refer to those 21 sleep labs in Malaysia. So we need to develop a model around this. So what I propose is screening and evaluation should be done by the general practitioner. Therapy and long-term care should be done by general practitioners supported by the specialist across Malaysia, and industry can play a role in it. Now, coming towards the end of my talk, I must highlight that Sleep Disorder Society of Malaysia have done a considerable good job in last 10 years time. That, and I'm saying 10 years because I have been observing them for almost 10 years now. They hold a very high quality annual conference. They hold very high quality annual road shows in different cities. They have excellent line of speakers. They cover the topics very well relating to different sleep disorders and sleep in general. Recently, they have started a webinar series. You can go to their website and you can find webinar education. And we are starting this webinar education on 31st March. The first webinar is happening on 31st March. And Sleep Disorder Society of Malaysia is also looking at GP education, and that is under planning. This brings me that Malaysia, there is a need for wake up in regards to sleep. Sleep disorders are prevalent in different disease states in Malaysian population. Population-based estimation of prevalence of sleep disorders need to be done. Disturbing sleep and nap patterns are present in students. And because of that, community education regarding healthy sleep habits need to be done. Topics regarding sleep physiology and sleep medicine need to be included in the medical curriculum, and that is very much possible. GPs should be included in the care of OSA, and we need to develop alternate models which boost their confidence in treating OSA. GPs in Malaysia have good knowledge about OSA, but we need to boost their confidence in treating OSA. Sleep Disorder Society of Malaysia should continue to do the good work to develop sleep medicine in Malaysia, and as industry partners, we are always there to support the Sleep Disorder Society of Malaysia. With this, I thank, and let's wake up and take care of our community, our patients, and make their sleep better. Thank you so much.